Hi, my name is Anthony Biziano. I'm a nursing student in the master's program at Eastern Kentucky University for the Psychiatric Mental Health Nurse Practitioner program. And the project proposal that I had focused on for this project was the collaborative, using the collaborative care model to integrate services primarily through the care coordinator for mental health provision of care in the primary care setting following the identification of primary care patients with depression or clinical depression symptoms. um, the significance is that depression is it is one of the most common mental health diagnosis, illnesses, disorders globally, and it also for both the individual and economically for businesses has the greatest impact on productivity, lost wages. So it impacts the individual in terms of money they're losing. It impacts the businesses in terms of production and unexpected call-outs, absenteeism. And so to identify these people in the setting that they're most likely going to have contact with providers, which would be the primary care setting, you would have to have appropriate screening. And then beyond that, you'd have to have a safety net to ensure that they don't slip through the cracks. So simply identifying them with a screener is great. Knowing who's depressed is great, but not following through and then having the additional services in place to actually provide for the care that they need. And it could be anything from antidepressants or even just simple counseling combined with antidepressants, or all the way up to a specialty mental health care, in which case you would have to have some safety net to ensure that in the transition of care they don't get lost in the shuffle, which is a common complaint. The proposal itself is the integration of a trained behavioral health care coordinator to improve the efficiency of provision of mental health services, as well as the transition to higher levels of care for those identified as clinically depressed in the primary care setting. I used the theoretical model of Nola Pender's health promotion model because you're constantly reviewing the environment that the individual is in, and you need to maximize their environment. So the environment that we'd be identifying here would be the person is identified in the primary care setting, but what do they need to do to change that environment and to promote their own health? So you'd have to put them in a position where they feel like there's frequent contacts, they have a really consistent resource that is going to stay in touch with them and make sure that their care is moving in the direction that they like. They haven't been forgotten. That's a big key component. So the care coordinators would be a specially trained person. I personally would feel like a nurse would be the best selection for that. You'd have a primary care nurse who receives some specialty training as a care coordinator or a behavioral care coordinator, and they would operate as the go-between. They would allow for work offloading for the primary care providers onto them so they could focus on their tasks, which would be more primary care based. Any transition of care, they would stay in contact with the patient until they were actually seen by the next level of care, to make sure that we don't just schedule appointments and then say, okay, well, this is your appointment date. You would actually follow up and make sure they attended the appointment, if not, why. And then you continue to do that until they're actually transitioned to that level of care, or symptoms abate and they're able to go back to functioning the way they were. And then you can, there would be additional decisions. Do you continue to follow these people or not? So all primary care patients, as far as the implementation of the plan, you would initially have these trained nurses or professionals, whoever is determined to be the candidates. The plan itself would be nurse-led. That's per the NIH. As you expand the nursing profession, you want to make sure that you're enhancing the roles and responsibilities. Nurse-led interdisciplinary team. They'd meet monthly in order to ensure that the goals are being met. Now, these are the pathways that you would want, and the pathways would be clinical, operational, and financial pathways. So initially, you would establish your plan in month one. You roll out the plan. Every month, have an interdisciplinary team meeting. You discuss all the pathways and determine what are the shortcomings, what are the pitfalls, what do we need to do better or different to make sure that we're moving in a positive direction for both the patient and the facility. The patients, to amass your data, you would use the PHQ-2. The PHQ-2 had a 95% confidence interval of identifying clinical depression in patients When compared to the PHQ-9, this is a brief, the brevity of it, obviously 2 questions would benefit everybody. It keeps the time down as far as the assessments in the primary care setting. Patients could tolerate it well. It's significantly reliable, statistically reliable, I'm sorry. And so that would be the initial. From there, anybody screening positive, which would be great, 3 or greater, then you would transition to the care coordinator, the specially trained personnel, and they would do a PHQ-9. That's your baseline that you would utilize to ensure that you're making progress for the individual. A database would have to be created. You could make it accessible for all the care coordinators on a shared file. From there, they would track the individuals per policy, whatever policy you create. If it's weekly initially for 3 weeks, then you would do your weekly follow-ups and then see if there's any additional changes. Then you can make it every 2 weeks, every 4 weeks, so on and so forth until you get to either. You see the clinical outcomes. There's an improvement in clinical outcomes or there's not, and then you'd have to make a decision. Does this person need to be transitioned to a higher level of care? And at that point, you would communicate with psychiatrists or mental health care professionals that would provide the services required for that individual. Again, as far as the timeline, the rollout, most of the programs I had seen as far as the training were anywhere from 3 to 7 days to establish a certification for care coordination or care coordinators. It might be longer specifically for mental health. I wouldn't think so though, than 7 days. That should be sufficient. Continuous data collection, you're going to do that on a daily basis, a patient basis. Of course, you do your PHQ-2, and then you would offer the service of enhanced contact through the care coordinators for patients, and if they can provide their consent, then of course you refer them into this program. Monthly team meetings, that should be sufficient to review any pitfalls, shortcomings, and to highlight the benefits of the program, both for the institution and for the patients. And then at the 6-month mark, I would say yearly or a 6-month evaluation, really in-depth, deep dive of the data. Are things getting better for the patients? Is it cost effective for the facility? Do we need to add more care coordinators? Do we have too many care coordinators? Do we need more computers? Is the database sufficient to track these people? Can we update it? Are there any other pitfalls? Billing, is there going to be billing issues? Can we bill the patient's insurance when we get to the point where we're providing these additional phone calls and allocating resources to them? So that would be considered reviewed at the 6-month mark. It would already be established in policy, but you'd review it and make sure it's adequate as far as capturing funds to make sure that the program can move forward. And then again, at the 12-month mark, you'd want to review it again and make sure that you moved in a positive direction, and that the ideas that you came up with at the monthly meetings, the 6-month mark, are being implemented and are effective. In closing, I would say that it is a new buzzword: integrative care, coordinated care, collaborative care. The idea is a very sound idea, that you would have additional services, especially for mental health in the primary care setting, because oftentimes primary care providers don't have the in-depth knowledge of the medications, and they're often a little apprehensive to provide treatment for mental health in the primary care setting. So to have somebody who's specially trained that can coordinate and offload some of that work from the primary care providers, I feel like they would feel a greater job satisfaction. The patients have a safety net, that they would feel better about expressing these feelings of depression and knowing that there is some positive outcome. Again, in that Nollapender model, having the positive, creating an environment where there's potential to enhance the quality of your life. That's what you want the patients to perceive, and that perception is really what would kind of propel them into a position where they would have the motivation, the desire to get better, and that would be the care coordinator's role. They are the safety net. And so in closing, I feel like it can be implemented anywhere in any facility. It's a simple training for very few people that would kind of take the bull by the horns, and they would provide these services for the system-wide, and it would do nothing but create a more efficient provision of care for mental health. Thank you.